think we are live, Dr. Irgau.
Okay, great.
Yep. Good afternoon. Today is November 12th, our Bariatric Friday with Dr. Irgau. This is American Surgery Center. My name is Kemal Erkan. I'm the chairman of the program. We are here to discuss another part of bariatric surgery process. So, because we have been doing this for a while now, there are times to time we actually have to repeat some of the sessions, but our patient base is changing based on who are going through the surgeries, and there are some new updates. So that's one of the reasons. So I'm going to ask Dr. Irgau to introduce himself, and we'll start the session.
Thank you, Kemal. Thank you for having me on another Bariatric Friday. My name is Dr. Irgau. I am a bariatric surgeon or a weight loss surgeon. I am the president of CHRIAS, or Christiana Institute of Advanced Surgery, and I have been performing weight loss surgery now for 20 years. And together with my associates at CHRIAS, we are by far the most experienced group in bariatric surgery in our area. So thank you again for having me, Kemal.
Thank you, Dr. Irgau. And I would like to introduce our other surgeons as well in the program, as they are doing cases right now, so they are not with us. So let's start. So as Dr. Irgau already introduced himself, and we have Dr. Gail Wynn, Dr. Michael Peters, Dr. Rahul Singh, and Dr. George Ibrahim on the bariatric side. And then we do have a colorectal surgeon, Dr. Sachin Vaid, and we work together with all surgeons under CHRIAS. And all surgeons are doing cases at American Surgery Center. So starting with the team who you would be working with, our registered dietitian, actually one more joining us soon, Fran, Amy, and Beth. They are specialized in bariatric process and working with our patients very closely. As Dr. Irgau mentioned earlier, we are more than 10,000 surgeries among 6 surgeons, and the last 3 years is at about 2,000. Now, why this is important is because in surgery, experience is the most important assets of the patient in a way, because your outcome is going to be depending on how good your surgeon is, and that's the most important part. Now, we have several different sessions that we have been doing, but today we are going to actually talk about the type of bariatric surgeries. And so before we actually start with that, like most of the patients, they do come to your office, Dr. Irgau, and they already do they already make up their mind, or do they know what they want, or are they asking you guys to make that decision for them before we start describing all these?
Most patients actually already know what type of surgery they're looking for. Mm-hmm. And it's interesting that most patients who come looking for bariatric surgery have been researching bariatric surgery for quite some time. In fact, it is something that they have been thinking for at least 2 years prior to approaching a bariatric surgery. In fact, when they first hear about bariatric surgery, most patients think they actually don't need that. They reject the idea outright. But then when they go on year after year, instead of really losing the weight they want to lose, gaining more and more weight and becoming sicker with it, then obviously they realize bariatric surgery is by far the most effective treatment available, and then they research it. And which procedure they choose depends really on what they've heard from other people who had bariatric surgery, be it family members, friends, or otherwise. But most people will have a fairly good idea of what they want when they come to our office.
Now, do you actually, after the first consult, do they change their mind?
Rarely. Most patients actually pretty much on their first encounter with us at the consultation, we go over their past history, we go over their struggles with weight, we go over their particular medical conditions, and then together we make a decision at what the best procedure would be. And once that decision is done, most patients will stick to it. Occasionally, patients will come and say that they've changed their mind because they've heard something different about the procedure, or they've been counseled by a family member to rethink it. But this does not happen very commonly.
I see. So now, before again we start with the actual type of surgeries, understanding the multidisciplinary approach is important. So other than our surgeons and our dietitians, we have our care coordinators, or our nurses, facility and practice. Well, there's also facility nurses, psychologists, and some of the other specialties who are part of the care that we are providing. Now, Dr. Irgau, the one thing that I like seeing here is, and we discussed the benefits of the bariatric surgery last week and how patients are improving, and with the 3 examples that we had. But this diagram here is explaining more than what we did last week. So we were focusing on 3 or 4 different very common illnesses, comorbidities that bariatric morbid obesity has. But this is amazing that patients can actually get to really good results for their other problems, because obesity, morbid obesity, is the root of all of these problems, right? So
Absolutely.
Now, if you can tell us what type of surgeries that's available and why we would pick one over the other one.
Absolutely. So, by the way, Kemal, the slide you just showed, the one with the multiple comorbidities, that is really one of my favorite slides. It's from the Mayo Clinic, and it's so defined so well, really the problem with morbid obesity. You know, from the outside, you know, when you look at a person struggling with weight, you think, okay, they are carrying so much weight, their quality of life is not great, they're having difficulty carrying certain tasks. But there is much more to it. Morbid obesity really is the root cause of so many illnesses that by getting rid of it, very often you get rid of so many medical problems. That's why primary care doctors are buying into bariatric surgery so much right now, because they are tired of treating diabetes, high blood pressure, sleep apnea, fertility problems, headaches, migraines, dyslipidemia, which is high cholesterol, many other problems just separately, right? When the root cause really is morbid obesity. And the great thing, Kemal, is that when you do bariatric surgery and get rid of morbid obesity, many of these illnesses either disappear or improve considerably as well. So really that's like, I love it actually, and I show it to patients quite frequently.
So Dr. Irgau, with the making the decision is probably really important for the patients, right? So in the past, we used to see lap band being very popular, and it's not something that we do as much anymore. But in terms of like going through these and just explaining to us why we would be getting one versus the other one, and how to make that decision, what's best for us.
Yes, clearly, Kemal, like you and I have talked in the past, the only option that is not acceptable in this day and age is to do nothing, right? To accept morbid obesity and to go on gaining weight year after year. That is totally unacceptable, right? Bariatric surgery is by far the most effective treatment we have, and any of those procedures would be better than doing nothing. Having said that, of course, certain procedures are best suited for certain patients than others. All these procedures are geared in some change on the digestive tract, right? The stomach, the intestines. If we start from the gastric band, the lap band procedure we have, which is the one you have on the left upper corner, with the lap band, what we do is we place a device around the upper portion of the stomach to decrease the amount of food the person can eat at a particular time. And the important thing about the lap band is that this tightness around the stomach is not constant. It can be changed. It can be tightened or loosened after the surgery without repeating the surgery, because of that little port that you have outlined right there. We can inject into the port. As you correctly said, this procedure was very popular about 8 to 10 years ago. We used to do many procedures, but we've come through also many problems associated with the gastric band, including the fact that there could be complications related to the band, but also the quality of life very often with patients having difficulty swallowing was a problem. And so we've moved away from that. But there is still an appeal to the gastric band. And the reason some patients really like the gastric band is that it is relatively reversible procedure. It's a device we're placing around the stomach, and it's a device that we can remove from around the stomach as well. So there is not a permanent change to the digestive tract from that sense, although obviously every time you do some surgery around the stomach or the food pipe, you are causing some scar tissue. So it's not totally irreversible. There are certain changes that occur because of the presence of the band, but for all practical purposes, it is a procedure considered as reversible. But as I said, it's not as commonly done nowadays as it used to be. Why we would do the gastric band nowadays? Kemal, it could be a patient's preference, right? And if a patient comes in and they really feel that that's the only option that they are prepared to see, it's certainly not for everybody. It doesn't apply to everybody. Is not a good candidate for the gastric band. But for patients who could be potentially good candidates, still the band is an option. The next procedure we're going to be looking is the one on the center upper procedure, and that is the gastric sleeve. The gastric sleeve is by far the most common procedure that we perform nowadays. And with the gastric sleeve, what we are doing really is we are reshaping the stomach. The stomach originally looks almost like a big watermelon, right? Very large, able to accommodate as much food as we can put inside it. And that's where we struggle, right? Because we don't feel full. The stomach can accept a lot of food. And whether we eat from, sunrise to sunset, it will just accept the food. And that's the problem with excess calories. So what we do is essentially we reshape the stomach by cutting the stomach along a specific line that removes the most stretching portion of the stomach, which is called the greater curvature. Now, that obviously creates some changes physically in that the person will have a much smaller stomach now, but more importantly, many of the hormonal communications with the brain that determine the level of hunger and our metabolic rate are also related to this portion of the stomach. And when we remove it, there is beneficial effect from a metabolic point of view as well. As I said, the gastric sleeve is by far the most popular procedure. In a way, Kemal, it makes sense for a lot of people, right? When you really look at the stomach, this large organ, and then you make it smaller, it makes sense to them that it would be the way to go. It is in our program an outpatient procedure, which means patients go home the same day. And we have brought it to a level of safety, which is really, really very high currently with very, very low complication rates. In fact, the safety of this procedure is comparable to procedures like gallbladder surgery or other procedures that patients undergo even later in their life, essentially.
So, Dr. Irgau, I have asked this question before, but just for our new audience to kind of benefit from it, so that one of the things that we do when we remove this plant is not just making the stomach smaller, and this is, sometimes like you are probably one of the I don't know, maybe mine is selective perception, but when you explain something to me, I totally understand very clearly.
Thank you.
So the way that I see here is this, yes, we have a smaller stomach now, but this section also is responsible for our hunger, right? If you can just explain that in the terms that I would be able to understand.
Absolutely, absolutely. So it turns out that the digestive tract is an extremely active system in terms of its ability to communicate with our nervous system, with our brain. And it communicates actively by sending back and forth messages, either through nerve pathways or even through hormones, which are little chemical messengers. Now, many of those chemical messengers that encourage us to eat are actually located in this portion of the stomach that we are removing, so that once that is removed, patients become much less hungry. In fact, many of our patients will tell you that they're not hungry any longer, and for months after the surgery, they will have to remind themselves to eat because they're not hungry. Now, why are there so many chemical messengers that really prompt us to eat? Well, because as human beings, Kemal, we have evolved to become heavy, right? To accumulate energy whenever we can get it. That's how we were really designed, how we evolved. And the reason for that is because for most of our existence, the biggest threat to our life was lack of food, right? So the ability to accumulate the food and holding on to it as long as possible really preserved us, helped us to survive for years. But now that food is so readily available, this ability is becoming a burden to us because we are struggling. And no surprise that with the wide availability of food, in all the societies that have no food problem, now you see morbid obesity becoming a major health hazard.
I have, maybe I should have asked this coming up question off the line, but I'm going to go ahead and do it. So I have to pretend that I'm the slow one in this session, right? So is the stomach is bigger? Does it mean that it has more, how the communication with the brain, there are now more things that's communicating with the brain? Does it have something to do with?
Well, absolutely. Surface-wise, when you look at the lining of the stomach from a surface-wise, it has a really big surface. So which means that it has many cells. And these cells are not just sitting there to be a wall lining to the stomach. So these are very active cells that have important functions in determining, in sensing the contents of the stomach and then sending messages back to the brain and getting messages from the brain as well and back forth. Now, clearly, we don't know all the intricate pathways that work in this system. In fact, one of the biggest challenges we have, as you know, is come up with a medication that could supplement what we're doing with surgery. We're far off. We're doing a lot of research. Scientists are doing a lot of research in this sense, but the complexity of the system is such that to unravel it all and understand all the particulate pathways that work here has been a major challenge, but we're making headways. And needless to say, though, it is extremely complex. But what we understood, really, Kemal, is that once you remove this portion of the stomach, many of those communications that were designed to get us, to push us to seek food, suddenly become silent. So we are able to be comfortable without food. Therefore, we're not hungry. Therefore, we eat less. Therefore, we utilize the body stores of fat for our needs, and we lose weight. And that's essentially what's happening.
So right now, it's one of the, well, I would say maybe 75% of our procedures are gastric sleeve.
That is correct, actually. That's spot on. Yeah, that's the number.
So, like, if the patient has difficult or different comorbidities, different illnesses, based on the situation that they're in, so we may not go with, although 75% is the sleeve, there's also another option with the gastric bypass, right?
Absolutely.
So,
Absolutely.
And like when you actually make that decision to go to gastric bypass instead of the sleeve, that may be helpful.
Absolutely. So, as you know, before gastric sleeve became widely available and became a preferred procedure for many patients, the procedure that we did for many years was the gastric bypass. In fact, when we started at CHRIAS, gastric bypass was by far the most common procedure we used to do, or 80 to 90% of the procedures were gastric bypass at that time. So it is the classic procedure that bariatric surgeons have grown up with, so to speak. However, gastric sleeve has replaced it as an alternative because with the gastric sleeve, there is no need to reroute the intestine. And that's the key difference between gastric bypass and the gastric sleeve. As your diagram shows, with gastric bypass, not only we are dividing the stomach, we are partitioning the stomach, but we are also rerouting the intestine, bringing the intestine to be connected with a portion of the stomach. That is really a very important change in the digestive tract. Now, it is obviously very beneficial in terms of the advantages of gastric bypass because when we reroute the intestine, we are also interfering with the body's ability to absorb the calories. And also, there are some other beneficial results in terms of interfering with the metabolism of the body in a beneficial way, particularly for people who have type 2 diabetes. Gastric bypass seems to work really well from that point of view. Having said that, rerouting of the intestine does come with some long-term implications as well, right? For instance, we can name 3 implications which are very important. The first one is that when you reroute the food away from that early portion of the intestine, which is shown as the green arrow in your diagram, actually we are going away from one of the most active areas of the small intestine in terms of absorption, which means also that not only we are interfering with the ability to absorb calories, but interfering with our ability to absorb very essential nutrients like vitamins or micronutrients, which means that a person who has gastric bypass is at risk of malnutrition from those nutrients for the rest of their life. And they have to be very careful about taking those vitamins and having their levels checked. So that's one issue. The second issue is that anytime you are moving the small intestine away from its natural position, you put it at risk for twisting. So bowel blockage can occur anytime after that surgery. In fact, about up to 10 to 15% of patients who've had gastric bypass are at risk of having another operation to undo bowel twisting that causes bowel blockage. And then another important point is that when we connect the intestine to the stomach, that connection by itself is vulnerable to the occurrence of something called ulcer. Ulcers can occur and ulcers can rupture, ulcers can bleed, particularly if a person is a smoker or they are taking medications known as NSAIDs. They are medications related to aspirin, Motrin, or Aleve, essentially, which are medications they can no longer take. So gastric bypass does come with potential implications in the future. Now, having said that, are there patients who absolutely would be best having the gastric bypass? Yes. And who would those patients be? For instance, patients who have very severe heartburn, very severe reflux that has caused severe damage to the lower portion of the food pipe, they would be better off with this procedure as opposed to the sleeve, because this procedure will allow us to really remove the acid-producing portion of the stomach away from the food pipe. So in that case, it would be preferable. Now, it's important that people don't misunderstand this, Kemal. It doesn't mean that anybody who has heartburn cannot have the sleeve. Far from it. Many people actually experience heartburn. So a low level of heartburn, some degree of heartburn is something that would not preclude the gastric sleeve. But people who have really on multiple medications of heartburn, they've suffered for many years, they have visible damage to the food pipe due to heartburn, they would be better off with the gastric bypass. Another advantage to gastric bypass is that it actually helps to control type 2 diabetes better than the gastric sleeve. Now, the gastric sleeve also is a good procedure in terms of resolution of type 2 diabetes, but it takes time for that to occur in terms of the weight loss and the metabolic changes afterwards. With gastric bypass, the changes to the blood sugar control could be almost immediate. And we've had patients come into the hospital in past years, come out on insulin, having surgery with gastric bypass, and they would go home without the need for any insulin with really good control of type 2 diabetes. So type 2 diabetes, which is very difficult to control, may be also an indication for gastric bypass as opposed to gastric sleeve. So all these are different, discussions that we will undertake with the patients before a choice is made as to which procedure might be best for them.
Dr. The ulcer and the smoking relationship, can you actually elaborate that a little bit more? Why is it more riskier for this group, for this type of surgery in terms of smoking and not stopping smoking early enough?
Absolutely. Absolutely. Kemal, if you don't mind bringing back the diagram of the gastric bypass. So where you had the gastric bypass procedure. So if you look before, on the before picture, right, where you have the stomach connected to the intestine, the connection of the stomach to the intestine lower down, right there, right, that connection where the stomach ends and the intestine starts, that is the natural connection between the stomach and the intestine. And it's designed in such a way that there is absolutely no problem there, any issues, in that connection. But when you connect the intestine in an unnatural way to the stomach, which is on the after picture where you see that blue arrow on the top, where you have the small stomach connected to the intestine, that connection by itself is vulnerable to ulcers. Now, why is that happen? It's not entirely understood. It probably has to do with the fact that a portion of the stomach still produces some acid, and that acid really damages that connection. Now, this becomes much more likely if a person is a smoker, and we've known that patients with a history of smoking are actually liable to get ulcers even if they haven't had gastric bypass. And this becomes an issue also if patients are on NSAIDs, these medications that I mentioned, aspirin-like medications. And that's actually the case even before the surgery. The stomach is really sensitive to this type of medications. But particularly, we know that when we connect the stomach and the intestine, that connection is vulnerable to ulcerations. And we've known this as surgeons for many years, even when we were doing connections of the stomach to the intestine for other reasons, like, for instance, to treat cancers. It's known as an ulcerogenic connection or anastomosis.
So, Dr. Is it like this section here is,
yes,
is almost replaced here, right?
Absolutely, absolutely.
Oh,
but the one that you have at the bottom is the natural one. It's designed by nature in such a way that there is no problem for ulceration there.
So that's like almost like, there's, I guess when there's a little bit more room in the stomach, so then maybe it does help with troubleshooting.
Yeah, so it is difficult to predict. There are some patients who are not smokers, who don't take NSAIDs, and after gastric bypass, they still get ulcers. So it's difficult to predict, but we know that the chances for getting ulcers is really much higher if the person is a smoker or they take NSAIDs. But we do know that that connection by itself is naturally geared towards the risk of ulceration in the future. So that's one potential implication of the gastric bypass anatomy.
So between the sleeve and the bypass, I think one of the main difference is the modification that's required on the natural stomach. Then on the bypass, then we are now getting into the intestine and then reattaching that, and then that potentially that creates a little bit more problem. In terms of reversibility, from or the options that you can actually do, like when we are explaining to the patients, we do say that you can go from band then to sleeve, from sleeve to bypass. But once we are on bypass, there's no other options.
Absolutely. The bypass, you can consider it as the final stop of the train, right? You cannot go anywhere from there, right? It's really, that's it. That's the also. Now, have people done reversals of gastric bypass with reconnection of the stomach and then change it to sleeve? They have, but these are really very extensive procedures that really, they create more potential problems as opposed to solve them. So when I talk to my patients, for all practical purposes, gastric bypass is an irreversible procedure. There's nowhere we can go once we've done the gastric bypass. As opposed to the sleeve, as you correctly said, from the sleeve, you can go to bypass. And people may ask, why would you want to change the sleeve to bypass? Well, there are situations in which patients with the sleeve can develop heartburn. And in a very small minority of patients, that heartburn may be difficult to control with medications, and then we can change them to gastric bypass. So you can go from sleeve to gastric bypass, but once you're on gastric bypass, you're there. There is nowhere else you can go to change the situation.
So, Dr. Irgau, I want us to cover one of the non-surgical procedure, which is the gastric balloon. We are the first one in the East Coast, I believe, right?
In the Delaware area, at least.
Delaware.
Yeah.
Pennsylvania, Delaware, New Jersey. I think there was one guy in New York, maybe. So now this procedure, I don't know if you still have your balloon. Last time when we were doing this, you had the balloon at your table. So if you can actually explain who would be the right candidate for this and how we do this one.
Absolutely. So the gastric balloon is the least invasive procedure we offer. And that is simply because there is no need to make any incisions on the skin to do the procedure. This procedure is done by using our natural opening, which is our mouth. So we would go through the mouth into the food pipe and then deposit this big balloon inside the stomach. Once the balloon is in the stomach, it creates a sensation of fullness because it stretches the stomach. And one of the ways for our brain to know that we're full is when the stomach is stretched. So by being a heavyweight stretching and weighing on the stomach, we feel as if we've had a Thanksgiving dinner all the time whilst the balloon is in place, which means that we end up eating less. So who would be a candidate? Generally, we say people who are likely to need less weight. For instance, people who are looking to lose about 25 to 45 pounds, patients who are in class 1 or class 2 obesity would be better candidates for this procedure. It is important to understand that this device cannot stay in the stomach indefinitely. In fact, it has to be removed after 6 months. So which means that after 6 months, the person has to rely on the habits they have developed whilst the balloon is in place for them to keep their weight off afterwards. Now, our program offers actually a 12-month engagement with patients when they've had the balloon so that they can see the nutritionist every month, not just for the 6 months in which the balloon is in place, but also for 6 months afterwards. It is non-invasive clearly because it is a device that can be removed if something happens and situation will come back to where it was. The procedure itself takes very little time to do. It is very similar to any other endoscopies that we perform, whereby we go through the mouth to enter the stomach, but it doesn't mean that there is no potential for complications. Of course, complications can happen with any of the procedures we do, including with the gastric balloon. With the gastric balloon, you can see things like irritation of the stomach, heartburn, abdominal pain, nausea, and vomiting also can happen. And then one of the more serious complications of the gastric balloon is that what happens if the balloon loses its integrity and starts leaking fluid, and then it becomes much smaller, where if it does that, then it can migrate outside of the stomach and enter the intestine, and that can cause intestinal blockage or bowel blockage that may require surgery. That fortunately is not very common, but that would be one of the more serious complications of the gastric balloon.
So I guess regardless of which one our patients pick, what we know is the outcome is going to be great because with the 99.4% satisfaction rate from our patients, we are the most experienced bariatric surgical program in Delaware. And I mean, this is not easy to achieve from what we have so far. Again, many people don't understand, but this is, 99.4. There's only one, so there's 3 more months to be 100%. So we can always improve, right? So and also, another nice thing is what our patients are sharing with us, and that's also kind of unique in a way that. When they start naming our nurses, our doctors, and taking their time. This is a full page, normally survey, but when we ask them if they have anything other than what they would like to share, and taking the time in writing all this is
amazing.
Really impressive, and I'm really happy, and I'm proud of our center. So. These are every week, this makes my day much better every time when I start the day with these patient responses, survey responses. So that's the best part of what we do, and I think the most rewarding part of it. Now, in terms of the different sessions we have, the Fridays we are set at 3 p.m. now. And then we have second and fourth Tuesday at 6 p.m. We have our full-fledged webinar. If you would like to know everything on the technical side, you can actually attend one of those. And we also have a Wednesday wellness webinar. We did one actually this Wednesday. This is second and fourth every month. And every Friday we have the UMACU update. And the best way to kind of keep the communication open with our patients is that if we are able to if we are able to improve the digital health, and that's what we have been doing with our patients, and I think we are seeing really good results. Now, Dr. Irgau, in terms of, do you have any kind of maybe interesting maybe anecdote of one of the patients, how they change their decision or how they make that decision that you would like to share?
Absolutely. Actually, not too long ago, Kemal, a patient was sent by their primary care doctors because they have morbid obesity, right? Their body mass index was close to 46, which is really very high. And the threshold for consideration for bariatric surgery, as you know, is a body mass index of 40. or sometimes even a body mass index as low at 35, but if a person has already comorbidities like type 2 diabetes, sleep apnea or hypertension would make them a candidate. So that person actually came out because they were told by their primary care doctor that they have morbid obesity now with body mass index of 46. They have high blood pressure. They have type 2 diabetes, right? And that's a person who is not, he's in their mid 30s, so young person, right? So when they came, actually, they did not want to hear about bariatric surgery. They were really, really concerned about bariatric surgery. That the fact of the matter is that bariatric surgery may be something that concerns people because of the immediacy of the potential complications. What patients don't often very see is that the long-term complications of morbid obesity are by far worse than the short-term potential complications of bariatric surgery. So the patient actually wanted to have medical weight management. They wanted to have either medications or others. And yet when you go through the history of the patient, they've tried it all. They've done so many diets in the past. They've tried other things. And clearly, every year they would lose some weight and then they would regain more. So it has been a yo-yo situation for almost 20 years for them. So they were looking for non-surgical means. And then when we really talked about bariatric surgery and where bariatric surgery is and how safe it is nowadays, then the patient actually was much, much happier at the end, and they wanted to go ahead with the sleeve gastrectomy. So one of the things I would like to emphasize, of course, is that this conversation that you and I have, Kemal, are general conversations, right? Bariatric surgery is still a serious form of treatment, and the final decision as to whether a person is a candidate for surgery and what they should have should really happen when they have a consultation with one of us, when they come and we talk to them and we look at all the pros and cons, the indications, the risks, the benefits, the potential complications, and whether they are applicable to their particular situation as well.
Sure. Well, Dr. Irgau, this was, as usual, it was every time I do these sessions, even though I know everything, I feel like I know everything, I learned something new. This happens with other sessions as well.
Thank you.
Understanding the root of the problems, and not just for this, but anything in life. Like instead of a patch, like kind of like putting a patch on the issues, we really need to go to the root of the problem and fix it there. It requires commitment in some cases, and also like you need help to make that right decision. And we are talking about like the group who have morbid obesity. We're not saying that everyone should be doing surgeries, and challenges are there, and we are here to help. So, Dr. Irgau, thank you for joining us. And
thank you, Kemal.
Next week, again on Friday, the Bariatric Friday. Thank you so much again. Bye-bye.
Thank you.